Pain is invisible but very keenly felt by patients with connective tissue disorders, and Dr. Helen Cohen is here to address this very potent issue. Dr. Cohen is a consultant in rheumatology and chronic pain at the Royal National Orthopaedic Hospital in Stanmore, and she has a niche in Marfan syndrome and Ehlers-Danlos. And we're really delighted she can join us. And we anticipate lots of questions in response to Dr. Cohen's talk. And so she's very kindly agreed to stay on and take these during the coffee break. Welcome, Dr. Cohen. Thank you so much.
Thank you. I hope everyone can hear me.
Yes.
Marvelous. Okay. It's a pleasure to speak to you all. I entitled this A Patient's Guide to the Galaxy of Pain. So, for those of you that aren't sci-fi fans, that's the Hitchhiker's Guide to the Galaxy. And that is the blood-batter beast of trial, which is a bit like pain, really. And it's said to be so stupid that if you can't see it, it thinks it can't see you either. And pain often sits in the background. As you say, there's this invisible monster, which is difficult to face. But actually, there are ways. So let's carry on. I have no disclosures. So, in overview, I'm going to touch on the different types of pain and then talk about how does pain actually work? Because if you're going to understand it, you need to understand what's actually happening. I'm going to touch a little bit on pain medications and on non-drug approaches, and then hopefully put it together in a summary for you. So let's talk about the good, the bad, and the ugly of pain and pain medications. It sounds a daft question, doesn't it? What is pain? You would have thought that that's pretty blinking obvious. Well, there are actually very clear definitions of it. As scientists, we love to define things. In the International Association for the Study of Pain defines it as an unpleasant sensory and emotional experience. So note that it's not just the sensation of pain, it's how the brain processes as well. Now, you can subdivide into two main types of pain, and that's acute pain and chronic pain. Acute pain is the sort of pain that we're all familiar with. This is what happens when you have an injury or damage. So this is if you stub your toe or sublux a dislocated joint or burn yourself. So this is sudden onset pain. You know all about it very quickly, but it does gradually resolve. And pain medications usually work pretty well for this kind of pain. Chronic pain, however, is very different. And this is more the sort of pain that you see in association with some of you may have even been diagnosed with things like fibromyalgia, hereditary disorders of connective tissue such as Marfan's, Ehlers-Danlos syndromes. There's often associated chronic widespread pain as well. There's a whole list of chronic overlapping pain syndromes. And the difference here is that the pain doesn't stop. It just keeps going and going and going. And we think there are very different mechanisms behind chronic pain, which is why it's different to acute pain. So let's talk a little bit about how pain actually works. Well, we all have pain receptors. The official scientific name is nociceptors, and these fire in response to a stimulus. So if you have a strong enough stimulus that's causing injury or damage, that will fire your pain receptors. That will fire the nerves down to signal the nerves. They will then signal that and fire all the way up that nerve to the spinal cord. Once that signal gets to the spinal cord, those nerves connect to spinal cord neurons and they start firing. And now the spinal cord sends a message of pain right up the spinal cord through various tracts to the brain. And once that signal hits the brain, it activates a whole network. There's not one simple center in the brain that deals with pain. It activates an entire network. And that's because pain is an old evolutionary survival system. There are some congenital disorders where you cannot experience pain, and they are all associated with higher risks of injury, illnesses, and death. Because if you don't know you've got an infected cut or you don't know you've got an appendix that's burst, then you're not going to survive. So the pain has to activate a network, and that includes behavioral and emotional responses. Again, in terms of evolution, if something's causing you pain, the odds are you're going to have to fight it or run away in terror. And that means you also have to activate autonomic responses. Now, that's that side of our nervous system that we can't normally control or we're not even usually aware of. That's the half of the nervous system that controls your blood pressure, your heart rate, your bowel, your liver. So pain switches on all of these responses. So it'll switch on your heart rate, it'll raise your heart rate, it'll raise your blood pressure. So pain activates a whole complex network. And that is what is happening in acute pain. Now, what happens in chronic pain is those pain sensors, those pain receptors, they start to sensitize and they drop their threshold so that now a stimulus that before wouldn't have been enough to make that pain receptor fire, now it can. So those pain receptors are firing to much lower thresholds and they're firing more frequently and they're activating other pain receptors all around them that were happy, quiet, and switched off. They are now recruited as well. So now you have a barrage of pain signals coming in through the nerve into the spinal cord. That means those spinal cord neurons are also going to sensitize. They will also drop their thresholds. They will also fire more frequently. So now you have a constant barrage of pain signals hitting the brain. And the brain isn't going to sit there like a passive jelly. The brain is also going to sensitize. So you're going to switch on a whole series of networks that in response to pain that normally wouldn't be active. And this whole complex system is what we call central sensitization. And central sensitization describes how pain itself can change how pain works. So you can get more pain for less provocation. It's like someone's taken that pain volume knob, turned it up onto the top notch there, and you can't turn it down and you can't tune away from it either. And this whole complex phenomenon is what we call central sensitization. And this is thought to be the background to most chronic pain syndromes. And it's thought that when you have this in the background, this is why you have overlapping pain syndromes, because they have this in common. The difference here is that chronic pain is now a constant on signal. So pain isn't about damage anymore. Now it's about a sensitized, wound up, overactive pain system. And then add to that, pain is a qualia. Now we're getting into philosophy here. Qualia is the proper name that a philosopher uses to describe, this is the official jargon, an instance of subjective conscious experience. In other words, the perception of a sensation. So there we are. Hopefully you can see a red mug here. Now it's got coffee in it. That color, red, is a qualia. The smell of that coffee is a qualia. The taste of that coffee is a qualia. The trouble is, we can't compare between ourselves. I have no idea if the color red that you were seeing or the smell or the taste is the same as what I would experience. In fact, we know for some people it's not. So some people in the audience may well have red-green color blindness. So I know you're not seeing the same as I do. We know that people have neurodiversity. The way the brain actually processes and understands sensory information is quite different. And then here's a one classic example. Do you remember that famous photograph of the dress? I cannot comprehend how anyone can see that as blue and black. That's white and gold to me. So it just demonstrates that pain is also a qualia. It is a sensation of a perception, and we can't compare it between ourselves. So pain is what you say it is, but it may not be the same for you as someone else. So that's just giving you a little hint as to the complexity of chronic pain. It is not as simple as putting a painkiller into such a complex system. And this is why painkillers have a limited benefit in chronic complex pain. And it's a bit like a certain very famous Time Lord was once trying to describe time. And I think the original quote is, people assume that time is a strict progression of cause to effect, but actually, from a non-linear, non-subjective viewpoint, it's more like a big ball of wibbly-wobbly, timey-wimey stuff. Well, it's a great quote that describing chronic pain. It's more like a big ball of wibbly-wobbly, brainy-wamey stuff that we're just only really now starting to try to properly understand. So pain-killing medications are just one small tool in the box. And painkillers alone are definitely not the answer to living with chronic pain. There are a lot of other tools, and I'm going to touch on some of those. So don't forget all the other tools in the box here. That's the first message. So what pain mechanisms might be operating in Marfan's? Well, this is just a small sample. So there will be biomechanical and musculoskeletal pain mechanisms. So many of you will have the joint hypermobility. So you may well be prone to the subluxations, the dislocations, the musculoskeletal pain associated with that. You have long levers. That puts a lot more strain around joints. The flat feet cause a lot of biomechanical pain and instability. Scoliosis causes obvious musculoskeletal pain. Some, as we get older, we will all experience osteoarthritis to some extent or another, osteoarthritis being what we call the wear and tear degenerative arthritis that we will all experience. There will be increased rates of soft tissue problems such as tendonitis, bursitis, ligament and tendon problems. There may be a higher instance of neuropathic pains. And by that, we mean pain arising directly from either damage or abnormalities of the way nerves and the spinal cord function. So dural ectasia is a classic one that causes pain that is very poorly understood, but is almost certainly a neuropathic type of pain. You may well have spinal nerve root irritation, either from wear and tear or scoliosis or combinations thereof. And that's what pain clinicians call radicular pain. Those of you that have CSF problems, may either high or low, may well be familiar with that complex pain. Then there are visceral pains. This is the pain associated with internal organs such as bowel and bladder. And then you've got lots of complex factors that make all of these things worse. So chronic pain loves feeding off other problems. So if you have pain all the time, it's not surprising that many people have anxiety, depression, mental health problems, and that feeds off pain, and pain feeds into that. Chronic pain is associated with chronic fatigue, and chronic fatigue makes chronic pain worse, and vice versa. So these feed off each other. Chronic pain causes brain fog because pain is designed to catch attention. As we said, it's an evolutionary survival system. So it's constantly grabbing attention so stuff doesn't get processed the way it should, which is probably why we see so much brain fog. And then there are other factors. You may well find that in Marfan's, you're often a little bit more clumsy than other people around you. So maybe you're a little bit more prone to injuries as well. And that's just a few examples of different pain mechanisms that could be operating in an individual. And if that isn't enough, as I've already hinted, pain medications help to some extent, but they do not make this go. So that takes us on to here. When we're thinking about medications. So no pain medication is going to entirely remove chronic pain. So therefore, the balance here is how much it's helping against the side effects, and that's short and long term. So for anyone with chronic pain, this is what you're constantly doing. You're balancing how much that particular medication is tuning it down. Is it tuning it down just enough that it's allowing you to do more, to have a better quality of life, or actually you're being hammered by the side effects? Now, the other thing to note here is that I do a lot of teaching and lecturing, not just in the UK, but on international teaching platforms. And there are some very interesting differences between cultures and countries as to what's available and actually what is culturally acceptable. So what we consider in the UK as a standard, normal, conventional painkiller may not be thought of such if you cross the Atlantic or you go to another part of the world. Similarly, what we regard in the UK as alternative and complementary medicine in another country may be actually pretty standard approaches. And then there's what's culturally acceptable in that country, in that culture. And cannabis is a typical example. So there are these differences as well. So when we talk about medications for pain, what are the two main types that we're talking about? Well, I'm sure most of you will have experience of this. There are the analgesic painkillers. So these are the fairly typical painkillers that get used in all sorts of pain. And then there are what we call the neuromodulatory medications. So analgesic painkillers, again, most of you will be familiar with these, are things such as paracetamol, or if in the US, acetaminophen. Yes, it can be helpful. It is one of our milder painkillers, but it's usually tolerated extremely well. And actually, it can be very helpful. However, as we're all familiar, it's very dangerous in overdose. The other medication group that a lot of you will be familiar with is the non-steroidal anti-inflammatory drugs. And these are things like ibuprofen, naproxen, diclofenac, that's Voltarol. And these can be very effective in acute pain. So if you've got a strain or an injury or something like that, they can be very effective in acute pain. And although they're called anti-inflammatories, they don't prevent inflammation such as things in chronic pain. So, and the other thing we have to balance with these, their side effects that you're balancing, they can cause stomach ulcers. So we're always very cautious about that. Those of you that have asthma, some people can't take NSAIDs because it aggravates asthma. we know that the entire group is associated with a risk of stroke and heart attack. And particularly for people that are on the full dose every day, so they're on the full highest dose daily. There's clearly a small, but it is there, slight increased risk of cardiovascular side effects. So we often are very reluctant to give these sorts of medications to people that have high risks, so diabetic or have other risk factors for heart attacks and strokes. Weak opiates, now that's things like codeine and combinations of codeine. So in the UK, that's things like cocodamol, codidromol. Yes, these can also be useful in moderate and sometimes for severe pain. But again, what you're balancing up here is the side effects of a weak opiate such as codeine. And they're classically good at causing constipation. Some people, they can cause a lot of nausea and make you just generally a bit woozy. And of course, codeine, because it is a weak opiate, can be associated with tolerance, addiction, and abuse. So Eminem, when he's rapping about Vicodin, that's actually cocodamol. Now, the neuromodulatory group of medications, these are medications that are aimed to actually damp down nerves. Now, again, going a bit Star Trek here, you would have thought by now we would have a tablet that switched off pain nerves. We're not clever enough for that. We're a long, long way off that. That is the realm of Star Trek. But we do have medications that alter how nerves fire, and that will include pain nerves. And the one main group are the anti-epileptic or anti-fit medications, and that's medications such as gabapentin and pregabalin. They stop fits by damping down how nerves fire. So they will also damp down pain nerves. So they can help to reduce nerve-related pain and musculoskeletal pain. So we do use them sometimes if you've got severe nerve root pain from the spine, so the radicular pain. We do use them in things like fibromyalgia and other chronic pain conditions. But again, what are the side effects you're balancing? Well, in these ones, dizziness, drowsiness, and we do recognize weight gain. It's also surprising. I think if you try hard enough, you can abuse anything, but you can actually abuse these drugs. And they are the #1 drugs of abuse in the prison section, I think because a lot of the high-strength opiates dried up. So if you take handfuls of the stuff, you can get a high. So this is why this group of drugs are now controlled drugs, which they didn't used to be, but they are now. And you can't suddenly stop them. So typically you gradually increase them. So you titrate them up slowly. And similarly, when you stop them, you're supposed to titrate them down slowly because otherwise you can get a withdrawal syndrome. Now, the other group that get used quite a lot in chronic pain are the antidepressant groups because they alter how nerves fire, including pain nerves. But we're using different doses and for different reasons. And some typical examples here include amitriptyline, mirtazapine, duloxetine. So these can also help with nerve pain and musculoskeletal pain. And additionally, if there is associated mood and anxiety, then yes, they may help with that. Amitriptyline we often use when you have a lot of difficulty with sleep and pain at night, and we often use it then because it can make you a little bit drowsy. So if you take a tiny dose about 3 hours before you go to bed, it can sometimes help settle the sleep down. And given longer, it sometimes helps with pain. So yes, we use medications such as amitriptyline. Varying side effects to them. And for this case, it's duloxetine. If people are on full dose of tramadol, I wouldn't use duloxetine because you can get an interaction. Now, I'm often asked about muscle relaxants, and I think that's because if you have conditions such as Marfan's or Ehlers-Danios, people are often prone to a lot of muscle spasms and irritable muscles. Trouble with muscle relaxants, again, is they have some very nasty side effects. So my general advice is try not to. I don't recommend muscle relaxants where possible. If they are used, advice is to keep the usage very low and with caution and close monitoring. And mainly that's because the main group used as muscle relaxants are the benzodiazepines, such as diazepam, which are highly, highly addictive. And this is why if you've ever been given a course of diazepam, your GP will only usually give you a week or 2 weeks supply. They don't usually keep it going. The other problem is that when they're combined with high potency opiates such as morphine, there's a particular risk of accidental death in accidental overdose. And that's because both groups damp down your breathing drive, your respiratory drive. The other problem is if you give someone who's already got lax joints a muscle relaxant and you give too much, well, your already lax joints will all probably want to fall out more. So you have to treat these drugs with huge respect. So my general advice if people are complaining about muscle spasms isn't to put them on tablets. It's to actually focus on a lot of the non-drug approaches, and that may be appropriate exercises, stretches, relaxation techniques. Where muscles relaxants are used, preferably avoid diazepam, or if it is used, it should be short doses and with close monitoring. So I have got patients that 2 or 3 times a year have such terrible muscle spasms they've ended up in A&E, and actually a couple of doses of diazepam have stopped that, and it's prevented an A&E visit. And 2 or 3 times a year, that's quite reasonable. But when that's 2 or 3 times a week, that's very, very different. So strong opioids, this is things such as morphine. And I'm always asked about this when you've got chronic, horrible pain. Unfortunately, the advice is don't avoid high strength opiates. Having said that, there are the occasional patient who a high strength opiate in low, stable dose can help. But even then, that is with caution, with close monitoring, and usually under the care of a pain clinic. Now, by strong opiates, I mean things such as morphine. Tramadol is actually classified as a strong opiate. Tebentadol, pethidine, oxycodone, and fentanyl are probably two of the strongest that we use. So these have to be treated with enormous respect. The main problem is because they're not that effective for chronic widespread pain. You can give people enormous doses and they've still got the pain, but the side effect profile is appalling. So they're very, very good at causing severe constipation. They're very good at dropping blood pressure. They will impair an already impaired memory and concentration. They cause drowsiness. They all interfere with sex hormones, particularly testosterone, in a way we don't fully understand. They can affect immunity long term. They also have this unusual effect that if people are on particularly high doses, it can actually worsen pain. And that is something we call opiate-induced hyperalgesia. And if you take enough of the stuff, it really changes who you are. You still have the pain, but you don't care about it. But by the time you've got to that point, you're also not you, and you don't care about yourself or anyone around you. And that's before we've got into the risks of addiction, tolerance, etc. And we've already mentioned there are accidental risks of death here with overdose, or just someone hasn't noticed that they took the dose before. And there are risky combinations, particularly with benzodiazepines such as the diazepam and barbiturates. And this is why you've all heard about the opiate epidemic that hit the US so badly, and the huge numbers of people that have died as a consequence of high strength opiates. So yes, it's a tool in the box, but it's one that has to be used with extreme caution, care, and respect. Now, about 2 or 3 years ago, for the Ehlers-Danios Society, we had to produce a statement on the use of opioids when the pandemic and the opioid epidemic really hit. And it's still available on their website. And it basically says this, but it's there for you to look at. So, medication tips. I think one, and probably the most important, is recognize the limits of the medication and aim to get a balance that really works for you. And if you find that side effects are outweighing the benefits, why are you on it? And I'm always worried when people are on a medication that's causing a side effect, so you get a pill for the side effect, and that causes a side effect, so you get a pill for the side effect of the side effect, and you end up with an enormous list. Next tip is keep a good relationship with your GP. They will know more about you as a whole than the specialist is just seeing you at odd intervals, and probably even longer intervals with the NHS as it is at the moment. So do try to keep a good relationship with your GP. If you do have chronic, difficult to control pain, you may well be referred to a pain clinic for specialist medication advice. And just remember, and again, this is the sci-fi again, the Matrix, what works for one person may not work for another. So don't try pill swapping. Or a mate has got a pill that works really well for them, so you've got to try it. There may be a reason why your doctor hasn't suggested that for you. So it's not as simple as the red pill or the blue pill. It might be neither pill. And beyond medications, there are lots of stuff out there that people will sell you for chronic pain. You name it, someone's tried it. There's all sorts of peculiar machines available on the internet. There's all sorts of alternative and complementary medications. Firstly, beware of anything that's promising a cure, because if it's promising a cure, the odds are it's snake oil. and always check if it's going to interfere with your other medications. So some of the herbal remedies can be very helpful, but they can interact with other medications. So always check with your doctor or with your pharmacist. Now, I have no objection to people using complementary and alternative techniques. In fact, many of my patients find them really helpful. And that might be your acupuncture, your Reiki, your aromatherapy, et cetera, et cetera. So when people ask me about this, my advice is go ahead, fine, but think about some of the following things. Avoid anything that's dangerous or potentially damaging. And there is some craziness out there. For instance, there's something called the Marshall Protocol, and that advises you have to make yourself completely vitamin D deficient. So you have to cover up, you're not allowed to see any sun, you have to have your vitamin D trekked over and over again until you've virtually got none in your body. And then you have vast doses of antibiotics for months and months and months. It's absolute dangerous nonsense. So look out for anything that's promising a cure or is quite frankly potentially damaging. Look for qualifications, look for feedback. And if someone you know has had that, you might be able to get some feedback as well. And then ask yourself, can you afford it? And what happens if you actually find it really helpful and you keep having to go back for it? There's nothing worse than finding a treatment you think is wonderful and you get about three courses and then actually it has to stop because you can't afford it. That can be soul destroying. So just ask yourself, can you afford it? And is it something that you go to a practitioner and you become completely dependent on it, have to keep going back and going back and going back? So the general advice is try a series or a course, then stop, assess how helpful has it been, and is this something that you're going to continue with? And beyond medications, the importance here is of therapies, and that's things like occupational therapy, physiotherapy, psychology, and somebody that's using a proper, holistic, biopsychosocial approach. So that is looking at you as an individual, but also looking at you in context. What is the biology of the disease and the condition and everything else associated with it? What is the impact of that on you and all of those people around you and your environment and your situation? That's how you should be approaching chronic pain. So people often tell me that they've done physiotherapy, it didn't work. My response is you haven't found the right physio. They're all individuals. Some of them have particular techniques they prefer to others. So if you have had physio and it didn't work, it may be that you haven't found the right physio using the right approach for you yet. Occupational therapists, these are brilliant therapists to have on board. They are much more than just the gadgets and aids that we all know them for. So it's usually your occupational therapist that people know for advising about sticks and crutches and frames and walking aids. They're actually far more than that. So ROTs do a lot of relaxation, breathing, sleep hygiene, pacing techniques. And these are all essential chronic pain skills. So OTs, very valuable people. Now, particularly for Marfans, some OTs specialize in hand therapy, and this is true for our patients with EDS as well. And so a really good hand occupational therapist can give you incredibly good advice on joint protection, finger splints, so ovalate splints, if you've never come across those before, pressure mitts, thumb splints, bespoke molded thumb splints. So very useful people to know. Social support and social networks are really, really important. And for some people, housing, it's way beyond just medication here. If you're in the wrong housing with which you've got stairs you can't manage, or you're really struggling just to get around and you haven't got ramps, and things like this can make an enormous difference. And of course, we've got to recognize that all of these factors are feeding into how the brain and the body are feeding off each other, that pain, stress, emotion cycle. So for some people, pain management programs are particularly beneficial, and that's one of the things that we run at Stanmore. Now, a pain management program is not the same as a pain clinic. A pain clinic offers medications, blocks, interventions. A pain management program is about how you can cope long-term with chronic pain, focusing on the non-drug approaches. Now, every pain clinic usually has a pain management program attached, usually an outpatient-based one where you might go 9 to 5, 1 day a week over usually 6 to 7 weeks. And then there are a few places in the country that do residential pain management programs, such as ours at Stanmore, but there are only 7 in the UK, 3 of which are in London. Invasive approaches. So if you go to a pain clinic, then sometimes they will be offering injections and blocks. So if you had a particularly nasty facet joint, some of you I'm sure have had facet joint blocks, some may well have had nerve root blocks. Pain clinics will sometimes do things such as spinal column stimulators, but all of these are temporary relief. They're not long term. And again, you're still having to do that balancing of what are the benefits against the potential adverse outcomes. And it's the same for surgery as well. Um, Ideally, no one wants to have surgery. And if you have a hereditary disorder of connective tissue, the general advice is don't have surgery unless you absolutely have to. And when you do, there are additional risk factors. But there are other factors as well. If you already have chronic pain, no surgery is going to change that. So that chronic pain is still going to be there. There are some additional risks for post-surgical chronic pain. So if you've had an operation, what are the odds of, say, a knee replacement or a hip replacement? What are the odds of having chronic pain, even having had that replaced? Well, those risks are higher if you already have chronic pain, if you already have poor mental health, if you have neuropathic pain, if you have PTSD, childhood trauma. These are just a few of the factors that we know increase the risks of chronic post-surgical pain. The other issue, which is as relevant for Marfan's as it is for EDS, is that any joint stabilization operations have a much, much higher risk of failure. So if anyone's trying to offer to tighten up your loose shoulder or tighten up your loose knee, just think quite carefully. It's like tying knots in an elastic band. It's still going to be elastic, and there are much higher surgical failure rates. So you have to ask yourself, if it fails, how much worse could you be off? And then there's the huge issue of psychological aspects of pain. Depression and anxiety are what you would expect if you're dealing with chronic pain. It's not madness, it's not weakness, it's part of a brain stress response to having pain all the time. But if you have severe depression or anxiety, it does continually feed into that pain cycle in that vicious circle. So sometimes counseling plus or minus drug treatment, which allows you to regain that control, is important and makes a big difference, not just your physical health and your mental health, all of it together. So this is the importance of mind and body. You really cannot separate one out from the other. And so I still find it astonishing why so often doctors and patients think you can cut off one off from the other. Just deal with my pain. Don't ask me how I feel about it. Or the opposite. I'm just going to think about the psychology and I'm not going to address the body. This is crazy. You have to look at this holistically. So finally, how about a tip on how to approach your doctor? Well, just remember, many of your doctors are scared of you. You're complex. You probably know more about your condition than they do. So hot tips for working with your doctor. One, don't overwhelm them. If you've got some information, that's fine, but don't bring in an enormous lever arch file. That will terrify them. Just bring in the essential information that you need. Make a list of your key concerns, then target the top one or two that you really want the advice for in that visit. And then ask at the end of that visit, thank you, that's been really helpful. I do have some other issues. Can we make an appointment to come back and discuss that? If you do have other resources or specialists that would be helpful, offer them in a non-confrontational way. Say, I've heard or I've looked up this website. This looks like it might be very helpful. What do you think? Could we consider this? You'll probably find your doctor's very happy and relieved, and they didn't know that existed, so they'll be very grateful to you for signposting them that way. You don't always need a specialist. So sometimes a physiotherapist, because you need some quadricep strengthening to help with that knee, a standard physiotherapist is fine. You don't always need a super specialist. And most doctors genuinely do want to help and support you, but they might need your guidance on how to do so. So, in summary, your pain is what you say it is, but your pain is going to be different to others. Acute pain, we're much better at dealing with this, but complex pain and chronic pain, much more difficult. Look at the individual and the mechanisms operating in that person. And while painkillers may help, they're not going to make all the pain go away. And just remember, painkillers are just one tool in the box. Look at all those other tools, including the non-drug and the rehabilitation approaches. Remember, pain, stress, emotion, interaction, this is normal. And for some, psychology approaches might be helpful. So don't be afraid of psychology and psychiatry. It's just another tool in the box. And with that, I'll say thank you for listening.
Thank you so much for that brilliantly vivid talk, which puts it all into a big holistic whole. I think the chat feed has been filling, but just if I could quickly ask a question on behalf of a young mother who's in trouble. She has ataxia and she twisted her back awkwardly at work.
Oh, yeah.
Left her incontinent. She's taking amitriptyline and codeine to no avail.
Yeah.
She has a young 2-year-old and she's at a loss. She's had to borrow a wheelchair from.
Oh no, need this is the typical. You need a really good physio and probably a women's health physio helping out here. If you've twisted your back, physio is absolutely where you want to go. And a really good physio does a really good assessment. If they see something, they think, oh, this isn't right. Actually, you need to see a surgeon or you need to see a neurologist. They're usually very, very good at saying so. But yes, first of all, you definitely need a decent physio on board here. Um, Amitriptyline, it may help with sleep and pain at night, but ironically, it depends on the dose. Bigger doses can actually upset bladders. So if it's a small dose,
Yes,
it probably won't, but big doses clearly can. Um, uh, and again, a women's health physiotherapist may be very helpful here. And if you haven't had it, have you had urology advice? They may have been there before, they may not, but a urologist might be looking at before just assuming, putting it straight down and saying, oh, it's durolactasia, don't look beyond that, which tends to be what happens in things like fibromyalgia. Oh, it's the fibromyalgia, don't look beyond that. But actually, is there a problem with an irritable bladder? Do you actually have bladder instability because you've got detrusor instability or something like that? So again, you need your team. Did you say amitriptyline and
codeine.
oh God, yeah, there again. If it helps with acute pain in a small dose for a short time, yes. Long term, no. And if potentially it is because you've actually got a facet joint, an irritable facet joint, or you've tweaked one of the spinal nerves, then maybe a low dose of pregabalin or a low dose of gabapentin might be more helpful. So
Right.
these are the sorts of things you would be looking at. Is like, what is that pain mechanism?
Just some good physios. I don't know. They sometimes seem to be elusive.
They can, and this is why I think you sometimes have to, if you've seen one and that hasn't helped, you do sometimes have to look around that. Um, it is a bit it's one of these things out there. You get some people in the musculoskeletal triage services who are absolutely fabulous and really know what they're talking about, and other people you can tell within a couple of sessions that we don't get you or don't get what the problem is, and then it might be trying to ask very nicely, is there anyone else that's got other suggestions as to how I could approach this, or maybe just looking elsewhere. But I say it's usually that you haven't found the right physiotherapist. And some of them have particular speciality interests. So some of them will be much more spinal physios rather than general.
Exactly. So the chat box is filling. Julian's asked, are there strategies to prevent acute pain, for example, from planned surgery becoming chronic pain? Is there anything that can be done to plan and prepare before an operation, guidelines on when to grin and bear things, and when to push for action afterwards?
I think it's knowing yourself and knowing your body. If you don't have chronic pain, then there's not usually anything additional you have to do, except that one of the risk factors for chronic post-surgical pain is something called catastrophizing. And that's when, if you're someone that's got a very high level of anxiety, that can actually be a risk factor for chronic post-surgical pain. And if you've had that, if that's the way you've always been all your life, someone at very high level of anxiety and particularly sort of you can pick up signs in your body much quicker than other people, and you get that high stress and anxiety response, that's probably a higher risk factor. Now, obviously, if you choose surgery imminently, then you're there's nothing you can do at that point. But if you recognize that and surgery is some way off, then getting some counseling or some CBT techniques or learning some relaxation techniques could make a difference. And that's the power of the brain and the body. If you have chronic pain already and you're known to have chronic pain, then yes, there are some additional things. And you'd usually make sure that if you've got planned elective surgery, that you will have what they call an anesthetic pre-assessment, and you bring these things up with the anaesthetist. Because the anaesthetist should be aware if you've already got chronic pain problems. That means they'll take extra cautions and extra treatments before, during the surgery, and will have an eye out for if there are problems after surgery as well. So make sure that you are having an anaesthetic pre-assessment. Make sure your anaesthetist is aware so that they can take that into account. Now, I see people with particularly complex, difficult pain, including things like complex regional pain syndrome and some of the very severe neuropathic pains. And there are some additional considerations around that. And in the Ehlers-Danlos syndrome world, I don't know if it's the same in Marfan's actually. I don't know if anyone's asked. We see that people often don't respond particularly well to local anaesthetic. And we still don't understand why. And there's actually quite a lot of research trying to understand that. But if you're someone that previously has found local anaesthetic doesn't work, or you need lots and lots and lots, again, let the anaesthetist know.
Thank you so much, Dr. Cohen. That was phenomenal.
Absolute pleasure.
It really was. Thank you.